So my name is Michel, and I work over in the School of Nursing. And my partner here.
Hello, I'm Alexa Flanowitz. I am a faculty in the School of Social Work. Welcome, everyone.
So we're going to start this off, this Ground Rounds event, and thank you all for coming. This is the second one. We plan on doing this in spring and fall every year. So thank you for participating. And I just wanted to start off with the introductions, not only of the two of us, but I'm going to format how this is going to occur and what we've got planned. I'm going to be the time Nazi, so I will ding, 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 okay? This morning, after we have the introductions of the panel, we have a case study for you to go to talk through and listen. You also are in groups and tables arranged multidisciplinary, okay? And that was meant for a purpose. I know a lot of you are in the same groups or in same classes, but we want you to share professionally the knowledge that you have in your particular discipline. So thank you all for bearing with us and splitting up from your friends and mates and kind of sharing your experience. At the back table here, we have some faculty experts, and up the back, who's trying to remain nameless and just snuck in, André. What will happen is they're going to introduce themselves as well in a minute, and from which school and faculty they work in, and they're going to be helping us with the with the small group discussion. So after the introduction of the panels and the case study information, we're going to break you in, obviously, into your tables. And up on the board here, we're going to have some questions that you can kind of discuss amongst yourselves in the small groups. And that's where our experts are going to walk around and kind of have input into that. And we have 2 questions that will come up on the board that you can address in your small groups. And we're going to ask that you take about 15 minutes each to kind of contemplate and discuss those topics. And then we're going to come back as a large group, and we've got 20 minutes allocated for that, where we can come back and talk about the interprofessional aspect of this, and questions from you, questions from our panel, and all of our participants. Okay, so without further ado, Alexa's going to introduce our panel. And thank you very much for coming.
Thank you, Christine. Okay. We've got a panel. You see them all here. I'm going to maybe walk behind each of them as I introduce them. First off here, we have Jennifer Stukey, LPN. She's the Chief Operating Officer of the Narcotic Drug Treatment Center, and she's going to be talking a lot more about her program as the event progresses. Thank you for being here, Jennifer. Next, we have Lynn Eldridge, who is a mental health clinician and the State Opiate Treatment Authority with the State of Alaska Division of Behavioral Health. Thank you for being here, Lynn. And then we've got Bill Trawick, who is a neonatal nurse practitioner with Alaska Neonatology, and he is the medical director for the NEST program at Alaska Regional. Thank you for being here, Bill. And then on the end, I won't walk behind all of you. We've got Linda Clapp Damerow. Did I say that correctly? Damerow. Oh, I didn't check in with you about your name. Who is a Protective Services Manager at the Office of Children's Services. So you'll be hearing from everyone up here today, as well as 2 special guests who have come with Jennifer, who I'll allow to introduce when she is sharing this morning or this afternoon. So I think... Oh, back table.
Hand it to him.
Okay.
Okay. You guys each get to introduce yourself, please, and the school that which you come from.
My name is Rachel Muir. I come from the School of Nursing. I teach exploration of behavioral issues in Alaska, an interdisciplinary course in the summer. I also teach public health in the nursing school, and I just wrote the psychiatric NP boards on Tuesday and passed.
Congratulations. My name's Kendra Sticka. I'm a faculty member in the Dietetics and Nutrition program, and I coordinate the bachelor's degree in dietetics.
Hi, I'm Pam Grogan. I teach in the School of Nursing. I teach OB, and I teach legal and ethical nursing.
And I'm Sandy Pence. I'm faculty and program director with the dental hygiene program at the College of Health.
Hello, everybody. I'm André, Rosay. I'm the Associate Dean for Academic and Student Affairs in the College of Health.
My part of this presentation, I want to run through a little bit of background of what addiction is, what we're doing to help people that are suffering from opiate addiction, and cover some of the symptoms that our patients experience prior to getting into treatment, what we do as nurses in the field, and then how we define success and what our outcomes are that we measure. So we all know that addiction is a chronic brain disease, and you can look at, great website, NIDA, National Institute on Drug Abuse. Dr. Noah Volkow has just time and time again confirmed that addiction is a chronic brain disease. And when we look at addiction, we're looking at behaviors. So some of us are dependent on things, dependent on caffeine, maybe we're dependent on our high blood pressure medications, but when we're talking about addiction, we're talking about the behaviors that people demonstrate when they are trying to get we'll just talk about heroin at this point. So they're doing things that they normally wouldn't do to get that drug so they can feel better, not even probably in high at this point, just better to make sure that they're not in withdrawal. So some of the symptoms that our patients, when they present to us, they are actively using and they're asking for help. They are self-referred. They're walking into our clinic or they're calling on the phone, and they have this vicious cycle of experiencing withdrawal and then not experiencing withdrawal, and they can come in the form of their they get their drug, they keep using this drug, they build a tolerance to it, they require more and more and more. They may switch from smoking heroin to finally injecting heroin, and to try to increase the rush, to get it into the system faster. And the cravings are, from what I have been just from feedback from our patients, just overwhelm their brain. They can't think of anything else. This is a full-time job. The heroin that they need to get to stay well and to avoid withdrawal is a full-time job, and that's what their brain is focusing on. There is nothing else that the brain cares about, because it is such a euphoric feeling for the brain. It feels so good to that brain that that's all it wants. And so they're in this cycle of obtaining drugs, selling drugs, getting their drugs, getting more drugs, constantly. This is happening for them. So when they come into our program, they present and we do a little screening on them. We need to make sure they're eligible for treatment. We make sure we are serving the correct population, and we have a no wrong door policy at our clinic. You come in and you're not needing treatment with us, then we will get you to the place that you need to be, which I think is very important. Because not everybody we're a methadone clinic, and not everybody needs methadone. There are other forms of medication to use, and that's why we screen our patients and do a thorough biopsychosocial assessment on them prior to them even seeing the medical doctor. So the role of the nurse is we're meeting with them immediately. They're doing their phone screening. We have to observe urine drug screens. We have to test to make sure that we have some form of opiates in their system. Sometimes they have methadone in their system. When we had a wait list, people were buying methadone on the street to try to treat their own addiction. And so we were seeing a lot of methadone positive UAs for people that were on our waiting list and trying to get into treatment. That's kind of gone away now, because we can accept patients as they come in. The nurse is working with them on harm reduction techniques when they come in for orientation. The nurse has a big role in prevention of preventing further disease. We are talking to them about HIV, hepatitis C. We're talking to them about safe techniques of injecting, if they're injecting drugs. Are they doing it safely until they can get in? We're a harm reduction program. So anything we can do to reduce harm to that patient is what we talk about with them. And we talk about now the Narcan kits that are on your tables. We have those. And anybody can have access to those at this point in the state. And we talk about using that kit and take that kit home, give that to your loved one, because if you do overdose, that kit might save your life. And so, like I said, prevention, harm reduction is hard to get your head wrapped around it sometimes, but it really is the best thing for the patient, and we meet them where they're at and meet their needs. After they're seeing the nurse and they get all this paperwork done, and they see the doctor, and he orders methadone if he feels that it's appropriate, then the nurse is seeing them on a daily basis, and she's administering the medication that is ordered from the doctor. And so that is a huge part of the nursing role. The second part is we have a few nurses that work for us, and so the other part is case management on the other side. So we have nurses that are administering medication, and then we have the nurses that are working with the outside agencies to make sure that our patients, other providers understand that they're on methadone. We might have to work with OCS. We might be working with the Nest if they're pregnant. We'll work with Bill. Another important piece that we see is after stabilization on methadone, the next step is referral to mental health, and they need a mental health assessment because about 85% of our patients experience some form of mental health issue that can a lot of times be corrected either with therapy or medication. So we work very closely with mental health providers to make sure that our medications are not crossing and hurting our patient. And the other thing that the nurses do, we do a lot of group therapy. We have an infant massage group, so we teach our patients how to do infant massage with their babies. We have a pregnancy and parenting group that all our moms get to come to, and then we teach, some of our nurses teach some stress reduction classes and some yoga, and we've really expanded our groups because I think groups are the most effective form of treatment that we've seen successful so far. So measuring success in a methadone clinic is not how fast can you get off the drug. Okay, it's not that in 30 days we're going to take you off. That's not success in a methadone clinic. The goal of methadone and medication-assisted treatment is retention. We need to retain our patients in treatment. The longer they stay in treatment, the more successful they'll be. And so we have about a 75% retention rate right now, which is about 25% higher than the national average. We look at all dimensions of their life, and we start addressing that, not all at once, but we slowly start addressing the dimensions of their life. The average time that a patient is in methadone treatment, according to the federal government, is about 5 years. And so that is something, as providers, when you see our patients, the first question shouldn't be how fast can we get you off this medication, because that's not good for them. And it's a very slow process to take them off. And there's a lot of things that a lot of life domains have to be addressed before we start taking our patients off this. And when you start working in the field, you're going to know that there is a wait list for everything. If you want to get somebody into housing, you're going to wait 2 years for that. If you want to get somebody down to get Medicaid, you're going to wait for that. If you want them to get a car, it's going to take a while. So you have to, it takes a lot of time. And in this state, particularly takes a lot of time for stable housing and reliable transportation and employment. And so it is a process. We define our success as the retention, no drug use, coming in for every encounter at the clinic that is required, whether it's dosing, individual counseling, or their group therapy every week. And they can be into 4 to 5 groups a week. I mean, this is, and it's required, it's not an option. So if it's assessed, they have to do it. And we define it as people employed. I mirror the Alaska unemployment rate right now. That's where my statistics are at. Our patients are working, they're around you, they're functioning, they're doing what they need to do because that methadone is just sitting on that little receptor site in the brain blocking cravings. And so we have a lot of patients that go back to school. We have a lot of patients that get their kids back. So That is a huge goal for them. So that's how we define success. Success is not getting off medication as fast as they can. I think the most important part of this is having a couple of ladies that I know share their stories and how they define their success. And so,
my name is Jamie. Methadone saved my life, no question. I used for about 10 years. I was in and out of rehab, none of which lasted more than a few days. My longest stay was 12 days total. In a 6-week period, I was kicked out of 4 different rehabs for various reasons. Finally, I ended up doing some bad heroin that gave me a heart infection, put me in the hospital. The attending doctor suggested, because I was obviously an addict, that I try methadone. The next day, I did an intake at the local methadone clinic. It wasn't magic, but it was the missing piece. After that, it took me about a year to really get clean, but eventually it happened. On December 16, 2013. I will be celebrating my 5-year sober birthday on December 16th. There was one slip, but that was what I needed to really realize and accept my addiction is forever and will always be a part of my life. Successful years on methadone, I felt I was ready to come off. I did very quickly, definitely too fast. Within 6 weeks of being completely off, I relapsed. The day I was completely off methadone, my ability to function on a very basic level was gone. I was counting every step because it took so much energy and effort to do anything. Just getting up didn't. Everything was like this every day. It was like this every day, and I kept waiting for it to get better, but it didn't. Or I kept waiting for it to subside, but it didn't. And eventually I relapsed. Also, while this was going on, I started to drink more and more, which was a red flag. In my life, but I learned a lot about myself and my disease. I realized how much methadone really did save my life. I may come off methadone again someday, but at a very slow rate. How slow? My dose today is 38 milligrams. If I decided today to start coming off, it would be at a rate of 1 milligram a month. That's over 3 years before I'd be completely. I have a happy, healthy 22-month-old daughter, whom I did have on methadone, and she is my purpose for living, an amazing fiance and supportive family. I finished my counseling training last year and am currently applying to be an addiction counselor myself. Because I was lucky enough to have found methadone, as well as some amazing counselors and hard work on my part. There was a time I didn't know or care if I was going to get up in the morning. Finally, finding methadone changed this. It gave me the chance to build the life I deserve. It saved my life, no question. Thanks for listening to my story.
I think maybe Lynn wants to address a few things as our state opioid treatment authority about the whole process. We are regulated from top to bottom, let me tell you. So Lynn is the one that watches us. Makes sure
What? I'm on a time limit. I can talk about opiate addiction and treatment for hours. It is our current national health crisis. You've been hearing it on the news. You've been watching specials, have you not? And our president declared a national emergency, our governor a state emergency. Addiction and epidemic. Do you know that 146 individuals a day die as a result of an opioid overdose? And that is way more than car crashes. It is our #1 health problem at this point in time. So it has a lot of attention, not necessarily.
As far
far as when you have a dental procedure. Often children are prescribed various types of narcotics when they have a procedure. And so we are all exposed to it. I bet if I asked, I'm not going to, raise your hand if you've ever had a prescription, a legitimate prescription for some type of opioid. Pretty much everybody would have raised their hand. And the United States is the largest prescriber in the world for this. So one of the things that people have a problem with is why in the world are we prescribing medications that have an opioid base in them when the problem is they're having opiates? There's a lot of ideology out there, a conflict, an emotional conflict. So the saying out there is we're just getting state drugs for street drugs. And it's a pretty hot topic and pretty controversial. So I could talk on and on about how the brain changes as a result of using legitimate prescription medications as well as heroin and other types of illegal opioids or opiates. I don't have time to do that, but let me tell you this. The brain changes, and sometimes the brain changes permanently. And just like something in your system, say you aren't able to produce insulin for diabetes, your body changes. It's permanent. Some people have type 2 diabetes, correct? And you can take medication for that. What do we ask people to do if they have diabetes? What kinds of changes do we ask them? Do we just give them medication? No. Why do we have a diabetes educator in our hospitals and our clinics? Because there's more to it, right? What do we ask them to do? People who have diabetes, what do we ask them to do besides take medication?
Check their blood sugar.
What's that?
Check their blood sugar.
Check their blood sugar. Okay, that's the medical part. What else do we do?
Change diet.
Change their diet. What other kinds of things do we have them do? Exercise. We have them, we deal with stress. We talk to them about meal planning. There's all kinds of things that go into changing their habits around having a diagnosis of diabetes type 2. If someone who has type 1 is pump dependent, are you going to tell them, okay, once you change your lifestyle, you're eating right, you're checking your blood sugar, you're exercising, you're having less stress, different kinds of things in your environment, you're changing. Now you need to get off your pump. Do you do that? Why? We're going to kill them. Okay, so here's the deal with people who have opiate addictions. Their brain has changed so much. When we encourage them to get off, we're basically saying you're going to go out and use again and possibly kill yourself with an overdose when we push that. And there are some people who are type 2 diabetics, so to speak, who over time are able to make those kinds of life changes. Their brain has not changed chemically enough where they are able eventually to get off the medications. The state of Alaska, we support 3 medications that are FDA approved. The first one that Jennifer talked about was methadone. Methadone is a full antagonist. It sits there on those receptors. You guys have heard of receptors, right? You're in the fields of medicine. You should know this. If you're a social worker, you should start knowing about the brain and how it connects. It sits fully on there, so when somebody tries to get high, that's not going to happen. It's sitting on that receptor. And the thing about methadone, although it is an opiate, it's a full opiate. People are prescribed it in a different form, not a liquid form. Jennifer will tell you if it's liquid, it is from a methadone clinic. They have little ID numbers on there. If DEA finds it somewhere where it's not supposed to be, they can track it back to a clinic, and DEA is all over it. I work closely with the DEA about regulating methadone clinics. They are fully regulated by the state and the federal government as a result of it being a full opiate.
So the second medication that the state promotes is buprenorphine. You may have heard it in other terms like Suboxone or Subutex. Subutex, I have 2 minutes, the frog just beeped at me. Buprenorphine, it's a partial agonist. It's a pretty safe medication. You have to be a doctor. Just recently, nurse practitioners and PAs are also able to take what's called a data waiver and be able to prescribe. We have about 75 physicians, mid-level practitioners who are able to prescribe that medication. And we say last time, those are the people who are willing to be on the list. There's some people that take it just as part of their CEUs and aren't necessarily interested in addressing this population. The next one is naltrexone. You've heard of it, called Vivitrol. It's an injection into one of your biggest muscles, and you all know what the biggest muscle is, right? It has to be deep inside that muscle, or it can cause some injection site problems. It lasts between about 28 days to 30 days. Any physician or mid-level practitioner can use that medication. I want to talk real quick, even though I have 1 minute, about success rates. This is really important that I want to emphasize. 5% of individuals who decide not to use a medication when they have an opiate addiction are successful. So that's 95% of individuals who try to go through detox and go through what they call a sober treatment method are not going to make it. 95% of them are not. Because the brain has changed. Just like the body has changed, and that's really important to remember. Methadone has about a 65% success rate. Buprenorphine is right about the same amount. And Vivitrol is much lower. At about 6 months, it's about a 10% success rate. So, and I could talk more about why that is, and it calls anhedonia. I don't know if you've heard that term, but that's an important thing when you are treating a patient with social work or in any other field, is understanding what anhedonia is. That is all I have because I have been told to hush. So,
you have a form as well, the handout is with.
Thank you. Well, the diabetes analogy has been around for a long time. I'll show you this, which is connected to me, because I'm an addict too. I'm an insulin addict. If I don't have this, I can't be a productive person of society because I'm going to be blind. I'm going to worry my feet are going to fall off. It's no different than the person who needs methadone. You really need to come to accept that, and in doing so, accept that addiction is disease. Because diseases are treatable, and we can do this. So I'm going to devote my little time to perinatal substance use, and the end product of that is a substance-dependent baby. Babies aren't addicts. Babies cannot have an addiction. An addiction refers to a lot of psychology. There's a lot more to addiction than just needing a drug. Babies, they just needed the drug. That's all. When I started the NEST program, my initial goal was just to treat these babies because we weren't doing a very good job of it before, and I wanted to do it better. And so we learned how to do it better, and then it became glaring obvious that I was not really doing anything at all. Because to just treat a baby, well, that's so far downstream of the whole issue. It's just going to happen again and again. I'm not accomplishing anything. Maybe I'm making this baby's transition to an abstinent life a little better, but in the end thing, I'm not really improving his life. So we have become more involved in perinatal substance prevention. This slide you see here shows, this is information from a state epi bulletin that came out in 2016, which just talks a little bit about the rate of rise. You see in 05, 1 per 1,000, up in just a few years to almost 6.5 per 1,000. And you can bet it's gone up much higher than that. we have a huge problem. And so we've tried to change the culture of treating these babies. And this little thing at the bottom, that all babies who show evidence of substance withdrawal should be treated for that withdrawal. That doesn't mean they all should be on medications, but there are many, whoops, how do I advance here? That's what I hit, it just got bigger. There you go, thanks. There are many things we do, especially in our NEST program, that are geared to what we call non-pharmacologic interventions. A lot of those are common sense things: sensory reduction, physicality, holding babies. If only it was that simple, that'd be great. But it's not. The actual part of substance care for a baby is pretty finite. You know, we have an acute problem, we can care for it with either these non-pharmacologic ways or we can give medicines. But that is such a small part of the process. And so this pyramid you see here is a little bit of insight into how we address it. First off, identifying these patients who are at risk. We need to know what babies are potentially going to have withdrawal in order to not only treat them, but to direct their families into support services. So prenatal care is the ideal place for that to occur. And whereas that doesn't sound that complicated, OB physicians, and I'm not just picking on them, but OB physicians don't want to go down that path. It's a difficult thing to work through. When they discover someone is using substances, well, then they have to do something about it, right? And that's too much for some of them to even go down that path. And that's sad, and it's a disparaging thing to say about my colleagues, but it is what it is. So we need to do a better job of identifying these moms, getting them into early intervention, like this methadone program, which, not just to pander to, this is an outstanding program. It is, my life improved when I became aware of their program. They do an incredible job. And they are responsible for so many healthy babies that you'll never know about, and that's a good thing. This next point is probably one of the most important things we deal with: family inclusive care. You cannot treat the baby of a parent when you have this adversarial, hostile, shameful relationship. The family doesn't want to be a part of this with you. They don't participate. They don't recognize the same things you're seeing and talking of. Families have to be a part of this solution because at least 50% of the time they're going to be taking their baby home from our unit. We have a painful statistic that 48% of our babies go home with their parents. So you know what the other part of that is, foster care, extended family. But for at least half of our kids, these parents are going to be taking care of the baby. So we must have a partnership with them so that they're part of this solution, so that they see the benefits of a healthier lifestyle. Evidence-driven medical management, that's, I'm speaking about the use of medicines particularly. We worked really hard to kind of protocolize our treatments, and they're still evolving, but they're a lot better now than they used to be. And then you see intensive parent support again. That is going to keep coming up each and every time. The medical part of my job is becoming smaller and smaller and smaller, and now I'm becoming more of a social worker, and I don't mind because I'm accomplishing more by doing that than I am by prescribing an opiate to these babies. Community entrainment, getting families back into what you and I might consider a normal, healthy life. Give them opportunities, give them options to do the right things. No mother, period, no mother wants to hurt her child. It just doesn't happen. Parents want to take care of their children. Some of them are not able to do so at the moment, but I am forever amazed and overwhelmed at the ability for people to step up. Like the speaker who was here, can change their life. That is immensely powerful. And it would shock you to see how far a mother can rise when they have a child to take care of. There will never be another opportunity in that mother's life as powerful as the moment she has a baby for her to seek sobriety. And the last part is family substance recovery. If there's no substance recovery for the mom, then there's no family. It will not happen. It won't happen. And OCS has to step in and do their take over and do what they have to do. That's not what we want. We want these babies to go home with their mother, if at all possible, but sometimes it's just not. So my role is about 20% medicine and 80% trying to be a good human being. And it's pretty cool.
So my name is Linda Clapp-Damerow. I'm one of the managers of the Anchorage Office of Children's Services. I actually manage the initial assessment unit. So I supervise the supervisors who supervise the workers who go out and conduct initial investigations. So when it comes to opioid addiction and the parents that we work with, some of you might think that we're just going to run on out there with the car seat, grab a baby, and go. That's actually not our goal. Our goal is first and foremost, when a report is received, our intake unit screens that and decides, do we even need to respond? Then what we do, if we do respond, somebody from my team goes out and responds. And the goal is to assess, just because a parent is an opioid addict or uses any other drugs doesn't mean, one, that they're a bad parent. It means they're a parent with an addiction, right? And it doesn't mean we're going to swoop in and take their kids, because there are a lot of other things that can be put into place to allow that child and other children who may be in the home to remain in the home with that parent, and that would be the ultimate goal. So the first things we do, we have to assess for three things in every investigation. One, did maltreatment occur? If it's a brand new baby, probably maltreatment didn't occur. The mom hasn't neglected the baby. The baby hasn't been physically harmed in any way, except for the addiction or the withdrawals. We have to assess, one, did maltreatment occur? Then we have to decide, is there present or impending danger? Present danger is, if we were to walk away right now, would that child be immediately harmed? Would they die? Would the mom hurt them? Would the father come in and hurt them? You know, that's present danger. It's going to happen. And then we have to assess, is there impending danger? In the future, a couple days out, if the child goes home, what could happen? We assess those things. And then if we can't identify present or impending danger, we look at risk. How risky is it for this child to go home? So if someone's actively using, it's probably pretty risky, right, that if the child were to go home. But then we have to look at what level of intervention we actually need to apply to the family. So for the woman who courageously came up and spoke today, we might look at, do you have a mom, your own mom, who can move into the home? And if you're high, she's there to take care of your baby, right? So you're not posing a safety threat to your child because your mom's there to manage that. Unfortunately, a lot of the time, we do have to remove children from the home in order to manage the safety threats and the risk to the child. I've noticed today we've talked a lot about moms. We can't forget that dads also contribute to this. A lot of our mothers have partners who, whether it's a same-sex partner or a opposite-sex partner, who are also actively using, and oftentimes don't support the mother in their desire to get clean and their desire to remain sober. So really quick, to the woman who spoke today, I admire your courage, and I thank you for committing to your sobriety and sticking with it, and I'm sure your child thanks you for that as well. So unfortunately, if we have to remove children from the home, our initial assessment unit will file a petition with the court. We'll ask for removal findings or non-removal. Oh, sorry. That's okay. Non-removal would be we want to leave the child in the home with the parent. We have other people in the home who can control for any safety or risk factors. If we have to remove a child, then they would hopefully go with a relative, tribal partners, Indian foster homes, or a non-relative, non-native foster home. And the goal would be to partner with the family to create a case plan to help them bolster their protective factors so they can safely reunify with their children and sustain those protective factors to the point where we never have to see this family again.
So from here, just want to consider we're going to break out into our small group shortly. And if you could just consider maybe not all of the team members that are possibly going to be in this collaborative effort for the family are present here. So these are some other participants that you might contemplate and include in your discussion for consideration when we bring up those questions. Nurses, dental professions, medical assistants, pharmacy, peer support, substance abuse counselors, psychologists, family therapy, pediatricians, social workers. There are a multitude of people that go in to the collaborative effort and providing comprehensive care for everybody concerned in this situation. So please kind of keep those individuals that may or may not be here in your brains and thinking about that when we break out into these sessions. Also, we need to consider the role of the patient and family as far as other issues: chronic disease management, peer support, self-care. We've heard that be spoken to as well. Advocacy, and of course that huge issue of communication. That could be a 5-day presentation in itself. Other considerations you might have during your discussions in these small groups about finances, employment, housing, relationships, health, parenting, and overall social interactions. First question that we'd like you all to consider is, what are the roles the various disciplines have in assisting patients with opioid use disorders? Please consider the tools on your table in your discussion.
And then also the counseling on medications. They are taking something like the methadone, to how to use it properly. So just counseling on medication.
Communication and direct relationship with the patient, but we also would always, if we don't have a chance to meet with them, work with other providers to coordinate their care, make sure we're looking at the database that they're starting out for dental prescribing, for dental prescribing and general prescribing.
Well, there's a lot of
responsibility
steps.
to
It's not as obvious as prescribing. Because what happens is they come in, the patient is taken,
Prior to that, pharmacist.
what you will see is them coming in at 2 days and that's when you start to get those and then like what you say, you can withhold the
Okay, that's what I didn't know if pharmacists could do that, I guess, to say, just withhold it.
Like, who are they to
but then
make that decision?
Yeah. In addition to that, you can reach out to the patient. They may or may not be subject to records, but you let them know what's going on.
Especially if you have time to hear their story. So we're going to be really important to what, like needing help or whatever, things like that. So, and we can also talk about oral hygiene and tools that they could be using to help with that. Instead of just the usual brush your teeth and floss.
So what we're supposed to be doing, who deals with that? Because I mean, that would almost be all of us at some point.
I have a feeling
be
it's like real life practice. See it more
doing most of it.
Hygiene.
I mean, I can't prescribe medications, but get medications, I can give it.
Generally, for us in the social work department, we are looking at what outside social supports that we can do. We want to find out about who are the initial supports in with that family, who is that individual living with, how are they involved in their community. For example, we may see somebody that went from having and they're very active in their community and in their faith community, and then has stepped away. So how would we help them reestablish that relationship?
We can look at what their malnutrition needs might be to get them back to better health. And of course, with a lot of deficiencies, that can definitely affect even mental status, physical status. So getting them back on track with their nutrition would definitely be key. I feel like that's like the key.
So that's pretty common. I think, are you guys aware of like, it shouldn't last very long, right? Like, you're not prescribed very, like a couple of days or something like that typically.
Yeah, it's usually like 6 pills.
For with your Yeah, well, getting, that was before I even got into this program. I barely knew what
I think I was like in high school, so my mom would give them to me, like,
So the question was, in my work,
need information. I don't want information because a lot of them it's a waste of time. But we would give them information about it. But that's the thing is a lot of times it's just like, well, I don't want medication. I've already waited, or I don't want information because I've waited this long. I just want to go. I think because I've worked in the dental field for many years and like I've seen patients come in and they literally want to take their teeth out to get drugs, you know, and like the office where I'm at, that's never going to happen. And even if it's if they don't disclose anything on their health history,
it's a red flag, right? Like how many of us go to the dentist and say, please pull my teeth out?
It's unfortunate, and you can tell. You can tell when somebody is seeking rather than, you know, they're there for an actual, I mean, maybe their tooth is hurting, but what, you know, where do you draw the line or who do you contact at that point saying this person is in here and they're wanting you to take their teeth out for pills?
What do you think your practice has like a protocol on that? Like if you experience that, what do you do?
If there's, within reason, if there's diagnosed reason that a tooth needs to come out, I need the drugs, then it's like tips or, you know, something for pain after the treatment is done. They have to do it that day.
Got it.
Like it's not, oh, here you go, here's pills, and come back if you want to. It's never like treatment is always performed if it's, you know, diagnosed that day.
What if you know they're actively painful? Like they don't really need any teeth pulled, and they're just like, pull them all.
That's a no-go.
What about interpreting studies and tests?
Our practice is like evidence-based, so if that's what you're asking, finding like an evidence-based way to combat issues like opioid use disorders.
Don't circle around the issue. Straight to it. So don't. That's really different. They appreciate that. They don't show that they appreciate that. They'll respect you. They're sizing you up to see what they can get.
When you're on naltrexone and this, the health impact is what happens if they get in a car accident. Now you have a problem.
The stigma surrounding the addiction also is the treatment. I think that's one thing that everyone can work on is, like you were kind of talking about, well, you're not really sure how people works into it. If we just want to destigmatize it, where we can start the conversation of getting referrals to social work but just spreading the information and getting that education out and making it okay to talk about. A lot of the problems that patients have with medication, you know, chronic disorders is that physicians and nurses and pharmacists and whoever else are not communicating, and so a patient will come in with X amount of meds, but then when they're in the hospital, they can only take hospitals that are at the, or medication at the hospital, and then that changes, and then when they go to their pharmacy, they're getting different medications, and it's just like, if no one talks to anyone, this is where people get multiple prescriptions for opioids, and they become abusers or things like that.
There's also other treatment. Okay, you got a treatment team that's working on a treatment team, and then you have a case manager or someplace else that's working on this and on you know, helping them find a job or something like that. And treatment saying, okay, well, you can't work in, it's not a good idea because you're not ready to be around substances, opiates or whatever, but now you're going to do it.
And I like what you were saying about everybody coming together, because, to be honest, nobody can know everything. And that's why we have all these different experts in different
Methamphetamine, you can worry about what are called punctate lesions in the head, just these small, little round areas, and they develop the brain tissue dies in these very small areas. And that shows up on ultrasound, but usually not until a little later. At birth, we only really use an ultrasound to find out if there were actual injuries, like in parts of the brain, or had bled, or damaged.
I think if they really didn't have like a support system as a family, would you just give them over to probably a better support system? Isn't that what methadone? Isn't that like the support system?
Well, methadone is a drug. We can offer them numbers or contact information, or maybe even make that phone call for them to send them to help. A methadone clinic, like she was talking about. Their support groups, maybe the emergency room, their support groups. We can help put them in line with getting the care they need.
I think it's something that's
anyone at this table can.
I don't think it's commonplace.
But for a pharmacist, it might be uncomfortable for them to maybe have those conversations. Or a dentist, a dietitian. It could be a hard conversation to have, but we definitely need to have it.
Yeah. Well, as you said, with the symptoms of your medications, when they talk about, like my thought was that when I look at what medications people are on, I look at what symptoms they have that may affect their intake, and then what they shouldn't have, and I never ever look at like, this could become addictive. That's just not something that...
It's interesting though, now that you've thought about it, right?
But I would still posture how in my scope of practice am I supposed to tell them, should I address this, or should I first transition if they haven't talked to you know?
I don't know, it's a good question to ask.
Yeah.
Working more as a team, then the patient really isn't playing off of each one of you for getting what you need, I guess, to say, or telling you what you want to hear, or I guess that kind of goes back to the communication part of it. So,
you know, a system where, that person is going to one doctor, the doctor's trying to do this, and the next doctor will see this in a system. Is there a universal system where they can see what's going on, tracking?
I feel like know what you're saying. Yes.
It's specific opioid.
Yes.
That's why we would get faxes, like if we did a prescription, they wouldn't fill it, and they would say they have these certain amount of prescriptions in the last 14 days. So that's why like we would know that they're shopping around.
Yeah.
Maybe it's not a question for you. I'm wondering how can they push more, if someone's addicted to a narcotic, how can they push more to either have birth control, depot shots, or have that in the actual facility for help? And then it might...
That's just, and trust me, I wish. I mean,
like if you want to come to the clinic, you have to have a depot shot, or, I mean, I don't want to say that, but...
I would even give them their drug if they would take it. That or IUD or something. It's okay to do whatever you want with your own life, but it's not okay to do that to your baby.
Yes.
So I just...
Or even if they came to the...
It's just more about moral, ethical issues than anything.
So, what's going on with your life? Even though I should probably know already.
And honestly, one of the health professionals that probably knows the most is my dental hygienist, because she does want to make that conversation with me.
Well, pharmacies separately for pseudoephedrine, like Sudafed things that you can only have so many within a month or whatever. But I don't know how that works. I think everyone just does that because it was like a federal regulation. So maybe if the government decided to put some kind of regulation on opioids because it's not OTC, then something like that would occur if they're filling out one pharmacy.
So we're going to come back into being one large group. And again, we've got a few questions to kind of think about and discuss. The first thing that we wanted to address, and thank you to Jamie and Sierra again for having the courage to come up and share your stories. That's what we need to know, and we need to hear from you what we can do better to make that successful and an easier road for you. So thank you for having that courage to come and talk to us. And I guess having that said, you know, I think it would be really important if you could share with us. We've been talking a lot about that interdisciplinary factor. And the question is, what is your experience with working with that interprofessional team? Did you do that? Did you get that? What was missing? What worked well? And maybe what didn't work well, to give us some insight into maybe something we could focus on in the future to make that healthcare from all aspects more successful for you and your families.
Dental hygiene we talked about earlier, there are a lot of people who bring a lot out of that. But for me, it was, I think the mental health aspect, it definitely goes hand in hand, but you get the addiction part of it, and then they kind of hand you a list, and the intertwining, I'd like more case management, I think, because once you walk out the door, it's kind of on me, and I'm in a position where, not so much now, but in the beginning, making a phone call to somebody was a big deal, like admitting where I was, and you know, that was a big deal. So more case management, I think, would have been more helpful for me. I have PTSD, so the mental health, parenting classes. You know, I'm a first-time parent, and I'm coming off of this addiction, like I needed help. I needed parenting classes would be a good one. And the only other thing, I was in an alumni program of some kind, connecting established recovered patients with incoming patients. So because I'm not so much a sponsor, but somebody that's been gone through it just a little further along. And that's the only improvement I can really think of. I've been really lucky. So, yeah. You think of anything?
For the hospital.
Oh, yeah, you had one.
You know, at the hospital, I had a hard time with judgment or my baby being called a drug-addicted baby or a drug addict, which is not happening. And I had 2 babies born on methadone. The first time I was not at the nest, and I had a harder time not being at the nest for the respect. And another thing is when you're at the hospital, you have to take a lot more medication because, like they said, at the clinic we get liquid medication. At the hospital, if your dose is higher, then you're looking at taking 30 pills at once, you know. So maybe this could work.
It's 5 milligrams. So
Yeah.
if you have a 130 milligram dose, it burns
yeah.
a hole in your stomach.
And that was rough, yeah. Maybe we take more care of those kinds of things, and nurses just being more understanding that this is a disease, and I don't want to choose to leave my baby or whatever.
Especially if they're an established methadone patient, they're doing the right thing. It's just the right answer.
Yeah. And it's still just treated like
that.
Yeah.
My Sticka baby is 22 months old, healthy, happy. There's nothing. You can't tell. There's
Exactly.
Only I know. Only my dad know. You know, like she'll never know. It was the right thing to do for the situation I was in.
Basic things like
again.
that. Yeah. I think.
Thank you. And it was highlighted by all of our panel speakers that this is a chronic disease and it can change brain chemistry in these, and there are patients asking for help, and we are in the healthcare field to help them and not judge them, and I think that's very, very important and crucial to them staying with us and having great outcomes. How about in your teams and from your tables, and what are the strengths or the challenges of working with a team? Any of our panel want to address that?
I don't know where I would be if I didn't have my supporting people. The social worker that works with our program, she is every bit as important as I am when we walk in there. It wouldn't be any kind of a program if we didn't have her. We use OT, PT persons to help do therapeutic exercises for the babies, help us manage some of their high muscle tone issues, which are really disturbing. It's a necessary thing to help with functional eating problems, but above anything at all, the social worker. Life revolves around her.
So he's referring to the hospital social worker, not the OCS social worker. But I can tell you as an OCS manager that working as part of a team is crucial, because we at OCS do not provide direct services to any client that we work with. We rely on other team members to do that. The NEST program, the hospital social workers, the doctors, the pharmacists, the Suboxone clinic. So working as a team is absolutely invaluable in supporting families, and part of that team needs to include social supports and family supports as well, because everybody needs somebody to turn to when they need help, somebody to turn to when they just want to talk. So they too are part of the teams. And don't forget fathers, they are always part of the team too.
So actually, I never really thought about dietetics. I'm in the pharmacy program, so of course people immediately going to think like you know a lot of education opportunities. But dietetics is interesting because one of the things I make of is the fact that maybe optimizing nutrition, etc., may help in that balance that the disease state. And so I've never really thought about that. But if you look at other mental disease states, like even like binge disorder, things like that, those are very directly dietetic related and also neurological problems as well. And so it's interesting because I never really thought about diet and how that may assist people that have opioid use disorder.
So I had the privilege of working with Table 1. One thing I realized was I'm doing this for a really long time, which is why I kind of look so haggard. But we never, I would say most of us at OCS or in CPS, Child Protective Services across the nation, probably never really considered, oh, let's get you linked up with a dietitian, because your addiction probably has taken a toll on your nutrition. Let's help you there. The pharmacists, they're one of our first points of education for parents who might have an addiction, or even in non-parents who might have an addiction, Dental. I can't tell you how many of our clients became addicted from a dental surgery, and they are also first-line defense in identifying maybe an addictive person's drug seeking, or just identifying, hey, just so you know, this can happen. I shared with Table 1 that I recently had 2 knee replacements. Pretty big deal. Got new joints in both legs. And I was given Percocet. Nobody ever came to me and said, hey, by the way, all they told me was this could constipate you. They never told me, do you know that you could get addicted to these pills? These are some of the signs you should look for. I didn't, because they made me vomit constantly. But no one ever had that conversation with me. So we really, as teams, we have a radiology technology student or tech here, and I thought, you know what, I had 1,000 x-rays, right? And if she was there flipping my legs around, I might blurt out, gosh, I could really use a hit of heroin right now because this really hurts. She might then be like, oh, I should go tell the doctor, right? I mean, we are all so valuable as team members, even if you think you aren't. You are.
That first table over there has some good comments, I'm sure.
Yeah, and the second table.
Pam's worse than me.
Everybody looks down.
Come on, guys, you can show
Telling the
it.
fibs? She's telling fibs. Okay. Thank you. Nope, you just.
Well, I guess kind of to more so what you were saying about that, one thing that I didn't realize is that it really is a team approach. I know as like a dietetics student, I wouldn't really know what to do, or and how we talk about just giving out resources and stuff, that everybody, the pharmacists, the doctors, everybody is kind of our own resources. And so realizing that it really is like a team approach, which I feel like when I walked in here was a little narrow-minded, and now is really big. So yeah, it's been good.
Okay, I have to talk for my group. Because they they not only realize that it's a very collaborative effort, but also that we work in rural communities, and we have a lot of rural. Stop that. Recording. But we also deal with a lot of rural clients. So if we have a client out in a rural area who unfortunately is addicted to some substance, we need to make sure that we're making contact with people so that they have that support, that collaboration, and that trusting relationship when they come into Anchorage also for treatment. So my group learned that. They might not want to speak on the microphone, but they were very good.
Okay. Thank you, group. Table over there in the corner.
I have a question for her.
Okay.
I was just wondering, do they have, in rural areas, do they have actually methadone clinics or clinics that can help?
No.
That would
so
be that.
how do they go about helping people in rural?
There's your answer.
It's very difficult. Like I said, methadone is a long-term treatment, and so you would be asking that person to come in to Anchorage to live, or Fairbanks. Fairbanks has a program also, to come and live and relocate to come to treatment. So there are options like Suboxone or morphine, which you can take a prescription and get prescribed 30 days at a time, which I think is starting to happen in the villages and the rural areas now, but it is very difficult. We take pregnant women from the rural areas, and we can keep them here, and hopefully they can find housing, things like that, have their baby, and then after that, they can either stay in treatment. A lot of times they just leave, they go back.
I have a question. Is there actually a team of people that helps the rural area women that have addictions and are pregnant to stay here? Is there actually no? So we are missing that.
They're hoping they have a family member, a safe family member in town to stay with.
But these people are so addicted. I mean, and they don't know anybody.
I know. We have a sober housing shortage in this community that is awful. There's nowhere to stay.
It's a big gap. And I think this highlights the social worker component. I know when I first arrived in this country, I was out in rural remote, out in the YK Delta, and to get any kind of external services is really quite difficult. And that's where that team approach, don't be surprised if you get a phone call, because that collaborative approach, especially, as Pam mentioned, from our rural communities, is vital, because you're the lifeline on the other end of a phone call, and that's sometimes all we've got when we're working in the rural sector. And again, we don't always have a dietitian or a PT or an OT that deals with children at all. I know out in the YK Delta they had PTs, but they only did adults. So what do you do with these little ones? So again, multifactorial roles and people on the team are essential.
One team member that we haven't spoken about are our tribal partners. We have to always consider tribal partners as members of the team. They often have non-traditional healing methods that work very effectively, and they are very influential in helping our parents who are addicted. So consider your tribal partners as part of your team.
And again, that cultural piece is imperative, because I know in that tribal community, that culture, it's not just about a single mother or father. There is a group of members, family members, that raise a child or a family, and that may be an option as well. So again, we need to kind of open our minds and thoughts about who is included in that discussion and in our intercollaborative team. Okay, is there anybody who has any specific questions for our experts?
I was just wondering if any of you guys could use an example of a challenge that you guys came across in a team and how you guys kind of dealt with it afterwards.
And we fixed this a long time ago, but our biggest barrier to treatment for our patients were nurses. They were just, our patients had awful experiences with nurses because of mostly because of comments, things, just being rude, and frustrated and angry with our patients because they were using heroin. And so we do a lot of education. We have nursing students come through and spend time with us. We work with the Nest. We work with Alaska Regional. Alaska Regional's nurses come through and spend time with us. We do a lot of education now, and it's not a problem like it used to be. But they were my biggest barrier to our patients getting access to medical care. So.
Along those same lines, when initially established the Nest program, our biggest, or well, I guess my biggest challenge was trying to educate the staff, nursing staff primarily, about the kind of environment that was necessary to treat these families. Zero shame. No one needs to punish these mothers, fathers, anything. We couldn't even begin to punish them like they punish themselves. So we do not need to contribute to that. We can't have a therapeutic environment if you're shaming someone. So I try to have, a pretty hardcore zero tolerance. But it will shock you because some of the nicest people who I work with will sometimes say something that is easily construed as a terrible thing. And I'll share with you just a horrific incident that is very fresh in my mind about a mother who was not doing well. She had just left treatment, and she was in a really fragile state, and herself was a FASD victim herself. So her intellect wasn't as sharp as maybe she looked. She went down to the Subway restaurant in the hospital, and when she's waiting in line, the two Subway employees were talking about how outrageous it was that their taxes were paying for these drug addict babies to be cared for. And that mother thought, of course, they were talking directly to her. She was down there with a meal voucher that was issued through the unit. So she thought, well, they know I'm a parent. She came back up to the unit, packed her bags, and was gone for 13 days. Didn't call, wasn't seen, and subsequently she has reestablished, but she is not participating in the care of her child at all. They destroyed her. She was already about as low as you could get, and they just threw the last fist of dirt on her grave. You can't do that. It's obscene. It accomplishes nothing. It's not just warm and fuzzy and a kumbaya moment for me to say you need to treat these people with respect. It's proven scientifically. If you want this child, in my case, to be a healthy person, then you need the parent. And to do that, to accomplish that goal, to treat them with anything less than a perfectly respectful and dignified, as a dignified person, it's not going to accomplish that. It's going to do the opposite.
So, kind of along the lines of what Bill said, one of the things that unfortunately we still see at OCS is people saying, oh, I got another drug baby, or that the crack mom I told you about. And we're really focused on changing that language. It's not the mom who uses crack. It's not the pain pill addicted mom. It's a parent who has an addiction. It's not a bad parent. So we too struggle with educating people on our staff on, look, you've got to be respectful and don't judge. It's not your place to judge. You don't know their trauma history. You don't know anything about this person. And our goal is to keep their children safe and to make them stronger parents. So we work on that regularly. But I can tell you a lot of people join the business thinking that we should remove every baby who was born to an addicted parent. That's just not the case. So we struggle with that too.